Welcome back to Rad Onc Smart Review GU Cancer Series. I'm your examiner for episode 23, and today we're focusing on testicular mock oral scenarios. Specifically, we'll be looking at stage I, stage IIA, and, the NSGCT variants.
Right.
Now, to you, the listener who's, out there preparing for your boards, I really want you to treat this as an active, high-stakes exercise. I'm going to present a clinical case and then ask a targeted board-style question.
And this is where you actually have to do the work.
Exactly. I instruct you to pause the audio, actually formulate your answer, and this is key speak your structured response out loud. Do that before you unpause to hear the model answer provided by our examinee here.
It makes a huge difference to actually hear yourself say the words.
It really does. So the overarching theme for our session today is, it's simple, but it's absolutely critical. Testicular germ cell tumor is really the ultimate toxicity minimization disease in radiation oncology.
Yeah, 100%.
For early stage disease, the board question isn't, can you cure him? I mean, the cure rates are exceptionally high.
Right.
The real question, the one that actually tests your judgment as a physician is, can you cure him without overtreating him? So think about that. Doctor, you ready for block one?
I am ready. Let's do it.
All right. We will begin with a case presentation. You are evaluating a 35-year-old man in your clinic. He recently noticed a painless mass on his right testicle. Ultrasound confirmed a 3-centimeter solid right testicular mass.
Okay, 3 centimeters right side.
Correct. He was referred to urology and underwent a right radical inguinal orchiectomy with high cord ligation. The surgical pathology returns as pure seminoma, PT1.
Got it.
His postoperative serum tumor markers, specifically his AFP, beta ECG, and LDH, they're all within normal limits.
Okay, that's good.
Right. A staging CT scan of the abdomen and pelvis is completely clean, and a chest x-ray is negative. He has no history of prior abdominal or pelvic surgery. And his fertility documentation notes that he has successfully banked sperm. So, doctor, what is the clinical stage for this patient? What are your decision points? And what are the standard management options you will discuss with him?
Let me organize my answer here. So, based on the provided clinical and pathological data, this patient has clinical stage IA pure seminoma.
Walk me through that staging.
Right, so I base this on the AJCC classification of PT1 that represents a tumor that's confined to the testes and epididymis without any vascular or lymphatic invasion.
Right.
And then it's N0, given the totally clean CT scan of the retroperitoneal lymph nodes. It's M0, given the negative chest x-ray. And finally, it's S0, because his postoperative serum markers have completely normalized.
Excellent. That's exactly right. Now, before we get into the management, walk me through the necessary components of his workup. Have we missed anything in what I presented?
Well, the workup you presented is it's complete and highly appropriate for standard board criteria. But I do want to specifically note the importance of the surgical approach here.
Go on.
The fact that it was a radical inguinal orchiectomy with high cord ligation, that is critical. We absolutely must avoid transscrotal biopsies or really any scrotal surgical approaches.
And why is that such a big deal for the boards?
Because the lymphatic drainage of the testicle follows the gonadal vessels directly up into the retroperitoneum. The scrotum, by contrast, that drains to the superficial inguinal nodes.
Right.
So violating the scrotum alters this natural lymphatic pathway, and it seriously risks seeding the inguinal node.
Precisely. Any other workup points?
Yeah. Additionally, obtaining post-operative tumor markers rather than relying solely on the preoperative values, that's mandatory to ensure there's no occult marker-producing disease left behind.
Very good.
And finally, confirming that he has banked sperm prior to any further intervention. That's just a mandatory quality of life decision point for a 35-year-old patient.
Excellent reasoning. You hit all the major safety and quality checks. Now let's move forward. Detail your management options and then state your preferred recommendation for this patient.
Sure. So for clinical stage IA pure seminoma, there are 3 standard management options to discuss.
Okay.
The first is active surveillance. The second is a single cycle of adjuvant chemotherapy, which is typically carboplatin dosed at AUC7. And the third option is adjuvant radiation therapy to the para-aortic lymph nodes, usually delivered to a dose of 20 gray in 10 fractions.
And out of those 3?
My preferred recommendation, and the one I would strongly counsel this patient to accept, is active surveillance.
Okay, doctor, justify your choice of active surveillance over adjuvant therapy. The patient has a confirmed malignancy, right? Why are we actively choosing observation?
Well, we prioritize active surveillance because, like you said earlier, this is fundamentally a toxicity minimization disease. I mean, the orchiectomy alone cures approximately 80 to 85% of patients with stage I pure seminoma.
That's a high number.
Exactly. So if we were to apply upfront adjuvant chemotherapy or radiation to all staged I patients, we would be severely overtreating the vast majority of them. We'd be exposing them to lifelong risks of secondary malignancies, cardiovascular disease, and, early hypogonadism.
And what about the ones who do relapse? Aren't we missing a window there?
No, because pure seminoma is just highly predictable in its relapse pattern. It typically appears first in the retroperitoneal lymph nodes, and it remains, frankly, exquisitely sensitive to salvage therapy.
Right.
Because the overall survival approaches 100%. Whether we treat up front or we salvage at the time of relapse, surveillance just avoids unnecessary treatment burden without compromising the ultimate cure.
It's the precise board-ready rationale. Surveillance dominates because the real issue is treatment burden, not a failure to cure.
Yeah.
But let's probe your confidence in this pathway a bit. Suppose the pathology report indicated that this tumor was, say, 5 centimeters instead of 3 centimeters.
Yeah.
And let's add that there was retestes invasion. How do these specific risk factors change clinical recommendation?
So a tumor size greater than 4 centimeters and retestis invasion, those are recognized historical risk factors for relapse in stage I pure seminoma.
They are. So do you treat?
Well, their presence definitely increases the mathematical probability that this patient will experience a recurrence in the retroperitoneum. However, and this is key, they do not change my primary recommendation.
Interesting. Explain why they don't force your hand into recommending adjuvant therapy. You just said his risk is higher.
Right, his risk is higher, but even with those risk factors present, the overall survival remains virtually identical under a strict surveillance protocol.
Okay.
I would definitely use the presence of a larger tumor size and the retestis involvement to, inform my counseling conversation with the patient.
What would you tell him?
I'd explain that his personal risk of relapse might be elevated, perhaps closer to 20 to 30%, which makes strict adherence to the follow-up imaging schedule even more critical. But I would firmly state that because the salvage rate for relapse is so exceptional, these risk factors do not force a transition to upfront automatic adjuvant therapy. Surveillance still remains the standard recommendation.
Very good. You are holding the line against the temptation to overtreat, which the boards love to see. But let's introduce a twist.
Sure.
You counsel the patient extensively on the benefits of surveillance, but he absolutely refuses.
Okay.
He has overwhelming psychological anxiety regarding a potential relapse, and he explicitly refuses systemic chemotherapy due to concerns about systemic side effects. He demands adjuvant radiation therapy.
Right.
As his radiation oncologist, you agree to proceed. Describe your exact radiation field, the anatomical landmarks, and the dose you will prescribe.
Okay, so for a patient with stage I pure seminoma who is, a poor candidate for surveillance due to anxiety and who elects radiation therapy, the standard treatment volume is a para-aortic strip field.
Describe the setup.
I would utilize an APPA technique or a modern conformal approach like IMRT or VMAT if requested, but heavily prioritizing the sparing of normal tissues.
Give me borders.
The superior anatomical border of the field is the bottom of the T11 vertebral body.
Yep.
The inferior border is the bottom of the L5 vertebral body, and then the lateral borders should provide adequate coverage of the transverse processes of the vertebrae. That's to encompass the pericaval, interaortic and the periaortic lymph nodes.
And what are the remaining testicle?
Oh, it is absolutely mandatory to apply a clamshell shield to the contralateral testicle. That minimizes scatter radiation, which preserves both his remaining fertility and his endogenous testosterone production.
State your dose and fractionation.
The standard prescribed dose is 20 gray delivered in 10 fractions.
Why such a low dose? I mean, for other solid tumors, we frequently escalate to 60 to 70 gray.
Because pure seminoma is just exquisitely radiosensitive. Extensive historical trials, including data from the MRC and RTRG, have clearly demonstrated that 20 gray in 10 fractions is highly efficacious for eradicating microscopic disease in this setting.
And escalation.
Escalating the dose further only serves to increase acute and late toxicities without actually improving disease control.
Name the organs at risk you are evaluating when reviewing this plan. and list the long-term counseling points you must review with this young man before he signs consent.
The primary organs at risk within and adjacent to the periaortic strip field are the kidneys, the small bowel, the spinal cord, and of course, the contralateral testis.
And what are you warning him about?
Acutely, he may experience mild fatigue and nausea. But, the long-term counseling points are far more critical for the oral boards. I must counsel him on the risk of impaired fertility, the potential for early-onset hypogonadism requiring testosterone replacement, a 1 to 5% risk of developing a contralateral testicular tumor, and, most importantly, the risk of developing a secondary, radiation-induced solid malignancy 10 to 20 years in the future.
Excellent. Let's evaluate a subcase twist on this exact patient.
Okay.
It's the same 35-year-old man. He still refuses surveillance. He still demands radiation therapy. But during your physical exam, you notice a scar in his groin, and he confirms he had a right inguinal hernia repair as a child. Doctor, since his prior surgical intervention in the groin has likely altered his natural lymphatic drainage pathways, shouldn't we expand the radiation field to a dog leg to cover the ipsilateral pelvic and inguinal nodes just to be safe?
Actually, no. I would absolutely push back against expanding the field.
Justify your refusal. Why wouldn't you cover the altered pathway?
Because prior surgery on the ipsilateral side, like a childhood inguinal hernia repair or an orchiopexy for an undescended testicle, it does indeed alter the normal predictable lymphatic drainage. It creates a risk that microscopic disease could drain into the superficial or deep inguinal nodes rather than directly up to the para-aortic nodes.
Right, so shouldn't we treat it?
No, because enlarging the radiation field to cover these unpredictable pathways effectively means treating a massive volume of the pelvis and groin, and that drastically increases the toxicity profile of the treatment.
And how does that relate to our core philosophy here?
Well, it directly violates the fundamental principle of toxicity minimization. I mean, the entire rationale for even offering adjuvant radiation to a stage A patient is that it's a small, well-tolerated field with minimal morbidity.
Exactly.
If his altered anatomy makes a clean, simple para-aortic field impossible, we shouldn't just reflexively enlarge the field. Instead, I would use this anatomical complication to re-emphasize to the patient that radiation is now a much riskier, non-standard intervention for him.
And your ultimate recommendation?
I would strongly reiterate the recommendation to return to active surveillance.
Outstanding restraint. You successfully identified the board trap there. The pearl for the listener is very clear. Prior surgery makes adjuvant radiation less clean, which must make you more cautious about recommending it, not more aggressive in your field design.
Right. You don't just blindly expand the field.
Never. Okay, let us shift to block 2. We are moving from adjuvant management to the management of active clinical relapse.
Okay, ready.
Consider a 38-year-old man. He is 18 months post-orchiectomy for pure seminoma, and he's been appropriately managed with active surveillance up to this point.
Good.
On his routine 18-month follow-up, his CT scan reveals a new 1.8 centimeters lymph node in the right para-aortic region. His serum tumor markers AFP, beta-HCG, and LDH remain strictly normal. Doctor, what is his current clinical stage, and what are your management options?
Well, because the disease has recurred in the retroperitoneal lymph nodes, he is no longer stage 1. A single lymph node measuring 1.8 centimeters classifies him as clinical stage IIA pure seminoma.
Give me the formal TNM.
The formal staging is NEPT N1 M0 S0.
Perfect. Define the standard management options for stage IIA pure seminoma.
The historical standard options for stage IIA pure seminoma are either definitive radiation therapy or cisplatin-based combination chemotherapy.
Are there any other modern considerations?
Yes. Modern guidelines also support that for highly selected patients with low-volume, marker-negative stage IIA disease, primary RPLND retroperitoneal lymph node dissection can be discussed as a primary treatment option, provided it's performed at an expert high-volume center.
Very thorough. Let's establish the exact treatment paradigms as the nodal burden increases. This is critical for the boards. I want you to walk me through the management ladder from stage IIA all the way up through a bulky stage IIB disease. How do your recommendations pivot as the disease volume grows?
I can lay out the ladder sequentially. So starting at the bottom for stage IIA disease, where the nodes are under 2 centimeters, definitive radiation therapy and systemic chemotherapy are both highly effective standard options.
Which do patients usually prefer?
Many patients and physicians actually prefer radiation here to avoid the systemic side effects of chemotherapy, given the relatively small target volume.
Okay, what's the next rung?
Moving up. Stage IIB disease, where the nodes are larger than 2 centimeters but do not exceed 3 centimeters. This remains shared decision-making territory. Both modified field radiation therapy and chemotherapy remain reasonable options.
And how do you choose?
The choice depends heavily on patient preference and specific anatomical consideration.
Right. And the top run.
Finally, the top row is stage IIB disease, where the lymph nodes are strictly over 3 centimeters. At this volume, the paradigm shifts entirely. Systemic chemotherapy becomes the preferred pathway.
Excellent. Now explain the radiobiological and anatomical rationale for why we abandon radiation for nodes larger than 3 centimeters. Why not simply, increase the radiation dose?
We abandoned primary radiation for bulky retroperitoneal disease primarily because of the rigid dose constraints of the surrounding normal tissues, specifically the kidneys and the small bowel.
Detail that for me.
To adequately treat a nodal mass larger than 3 centimeters, we would need to significantly widen the radiation field to encompass the gross disease with appropriate margins. And we would need to escalate the dose to sterilize the larger hypoxic tumor volume.
Which leads to?
This expansion of both volume and dose results in completely unacceptable rates of late renal toxicity and severe gastrointestinal morbidity. At that threshold, cisplatin-based chemotherapy just provides excellent systemic disease control with a much safer overall therapeutic index.
A thorough and correct explanation. Let's return to our patient. He has a 1.8 centimeters node, placing him cleanly in stage IIA. He elects to proceed with definitive radiation therapy. Describe your exact radiation field, your phase 1 dose, and your cone-down strategy.
Okay, for stage IIA pure seminoma, the standard radiation volume is a modified dogleg field.
Stop right there and describe the anatomical coverage of the modified dogleg field. How does it differ from the periaortic strip we used in Block 1?
So, the modified dogleg field encompasses the standard para-aortic nodes, but it extends inferiorly and laterally on the ipsilateral side to cover the external iliac, common iliac, and proximal internal iliac lymph nodes.
Why are we doing that?
It effectively covers the direct drainage pathway down into the pelvis on the side of the original primary tumor. And of course, we must still utilize a clamshell shield for the contralateral testicle.
Perfect. Proceed with your dosing strategy.
I will deliver the treatment in 2 phases. Phase 1 will treat the entire modified dogleg field to a dose of 20 gray in 10 fractions.
And phase 2?
Phase 2 consists of a cone-down boost. I'll shrink the radiation field to target only the gross nodal disease, the 1.8 centimeters node, plus an appropriate margin. For stage IIA disease, I will boost this node until the cumulative dose reaches 30 gray.
Okay, but what if this patient had a 2.5 centimeters node, making him stage IIB, but he's still elected for radiation?
For a stage IIB node under 3 centimeters, phase 1 still remains 20 gray to the modified dogleg field. However, the phase 2 cone-down boost is extended, bringing the cumulative dose to the gross nodal disease to 36 gray.
Spot on. Let me just reinforce the mnemonic for the listener here. The board standard dosing for seminoma radiation is 20, 30, 36. 20 gray to the prophylactic field. Cone down to 30 gray total for stage IA. Cone down to 36 gray total for stage IIB. Remember that progression?
It's a lifesaver on the exam.
It truly is. Now, doctor, prepare for a major board twist.
Bring it on.
We are evaluating the exact same patient. He is 18 months post-orchiectomy. The original pathology read pure seminoma. He has a new 1.8 centimeters right periaortic node on his surveillance CT scan. However, his new blood work reveals that his AFP is 42.
Oh.
And a rapid retest confirms it is actively rising. His beta-HCG and LDH remain normal. How does this rising AFP alter your staging and your management recommendation?
Okay. A rising AFP completely changes the diagnosis and the entire management paradigm. I must pivot immediately to the non-seminomatous germ cell tumor, or NSGCT pathway.
Explain the biological certainty behind that statement. Why does the AFP overrule the pathologist who diagnosed pure seminoma 18 months ago?
The biological certainty is that pure seminoma cells simply do not possess the cellular machinery to secrete alpha-fetoprotein.
What about HCG?
A mildly elevated beta-HCG can occasionally be seen in pure seminoma due to syncytiotrophoblastic giant cells. But an unequivocally rising AFP signifies the presence of non-seminomatous elements, specifically yolk sac tumor or embryonal carcinoma.
So the pathologist was wrong.
Not necessarily wrong, they just might not have sampled that specific microscopic area in the primary tumor. But regardless, even if the original surgical pathology didn't sample those specific cells, the rising marker in the blood confirms their presence in the relapse.
It's very nicely stated. As an examiner, I use a specific analogy to evaluate a resident's comprehension here. Think of a rising AFP like a fire alarm in a building labeled seminoma. You do not ignore the alarm just because the sign on the door says it is a safe building. You must treat the fire, which in this case is an NSGCT variant.
That's a great way to think about it.
With this pivot in mind, doctor, does radiation therapy play any role in managing this patient's 1.8 centimeters retroperitoneal node?
No, radiation therapy is now strictly contraindicated as a primary treatment.
Why?
Because non-seminomatous germ cell tumors are not exquisitely radiosensitive like pure seminomas. Attempting to manage an NSGCT relapse with radiation would result in local failure and, worse, allow systemic progression.
State your final recommendation for this rising AFP relapse.
I recommend good risk, cisplatin-based combination chemotherapy. Specifically, the standard of care is either 3 cycles of BEP bleomycin, etoposide, and cisplatin, or 4 cycles of EP, which is etoposide and cisplatin.
Correct. The oral board trap is anchoring on the historical pathology label and ignoring the AFP pivot. You've successfully navigated the trap.
Thank you.
Let's transition to Block 3. Having established the critical importance of histology and tumor markers, we will examine a primary NSGCT case from the time of diagnosis.
Okay, primary NSGCT.
You are evaluating a 28-year-old man. He presents following a right radical inguinal orchiectomy for a testicular mass. His pathology report reveals an embryonal, predominant, non-seminomatous germ cell tumor. It is staged locally as PT2, and the pathologist specifically notes the presence of lymphovascular invasion, or LVI.
Okay, PT2 with LVI.
His postoperative AFP normalizes to 3, and his beta-HCG and LDH are normal. A staging CT of the chest, abdomen, and pelvis is entirely negative for metastatic disease. He has no history of sortal violation, and sperm banking is complete. Doctor, state the correct clinical stage and provide your management options.
Let's see. The correct clinical stage for this patient is stage IB NSGCT.
Pause there. A common resident error is to see clean CT scans and normal tumor markers and automatically label the patient as stage IA. Explain precisely why this patient is stage IB.
The distinction lies entirely in the primary tumor pathology. In non-seminomatous germ cell tumors, the presence of lymphovascular invasion, where cancer cells are microscopically invading the blood or lymphatic vessels within the testes, that automatically upgrades the local tumor stage to PT2.
Go on.
So according to the AJCC staging manual, any PT2 tumor with normal nodes, which is N0, nodus metastasis M0, and normal serum markers S0, is strictly defined as stage IB.
And why do the boards care so much about that distinction?
It is crucial to recognize this because LVI is the single most powerful predictor of occult retroperitoneal micrometastases in NSGCT.
Exactly. The rule is PT2 with LVI and negative markers is stage IB. Do not call it stage IA with a risk factor. Now proceed with your management options for stage IB NSGCT, and I want you to explicitly compare this decision-making matrix to the stage IA seminoma we discussed in Block 1.
Sure. So for stage IB NSGCT, there is a genuine 3-way split in standard management options, and it requires expensive shared decision-making with the patient.
What are the 3 options?
Option 1 is active surveillance. Option 2 is a primary nerve-sparing RPLND, which is surgically removing the retroperitoneal lymph nodes. And option 3 is adjuvant chemotherapy, typically 1 to 2 cycles of BEP.
So why is surveillance not the undisputed dominant pathway here, like it was for pure seminoma?
The clinical logic diverges because the biological behavior of NSGCT is significantly more aggressive.
How so?
In stage I pure seminoma, the relapse rate is relatively low, and the salvage therapy is highly effective and well tolerated. In stark contrast, a stage IB NSGCT with lymphovascular invasion carries a baseline relapse risk that can approach 40 to 50% if left on surveillance.
That's practically a coin flip.
Exactly. Furthermore, if the patient does relapse while on surveillance, the required salvage treatment is a full-course, 3 to 4 cycle cisplatin-based chemotherapy regimen, which carries severe acute and late toxicities.
Right.
Therefore, intervening up front with a highly curative surgery like RPLND or a short course of adjuvant chemotherapy is a very compelling choice to aggressively reduce that high baseline relapse risk.
A well-reasoned distinction. Stage I seminoma and stage I NSGCT are fundamentally different clinical entities. Let us explore the surgical pathway.
Okay.
Suppose this patient chooses option 2 and undergoes a primary nerve-sparing RPLND. The surgeon removes the nodes, and the final pathology report indicates that out of 30 nodes removed, 2 nodes contain microscopic embryonal carcinoma. He is now pathologic stage 2. Does this finding mandate immediate adjuvant chemotherapy?
No, actually, not necessarily. This is a nuanced area of the guidelines. If the patient has low-volume pathologic stage 2 disease, which is often defined as PN1, and it was discovered solely because of the primary RPLND, returning to active surveillance is generally the preferred option.
Wait, justify the rationale there. We have proven that cancer spread to the lymph nodes. Why withhold systemic therapy?
Because the RPLND itself was a definitive therapeutic intervention. The surgeon physically removed the metastatic disease. While adjuvant chemotherapy is an alternative option that can be discussed to further minimize recurrence risk, it is not a mandatory sentence for low-volume PN1 disease.
When would it be mandatory?
The threshold to mandate adjuvant chemotherapy is usually reserved for a higher nodal burden, such as PN2 or PN3 disease, or if the surgical margins were compromised. For cleanly resected low-volume disease, observation spares the patient the toxicity of cisplatin.
Excellent. Very well defended. We will now move to the final subcase twist for Block 3, focusing on the management of post-chemotherapy residual masses. This is a critical area for board examiners.
Right, residual masses.
Consider a different patient. He presented with bulky stage IIB NSGCT at the time of relapse and was treated with 3 cycles of BEP chemotherapy.
Okay.
His post-treatment tumor markers AFP, beta-HCG, and LDH have all normalized. However, his restaging CT scan demonstrates a 2.5 centimeters residual mass in the retroperitoneum. Doctor, what is the mandatory next step in management for this patient?
The mandatory next step for a 2.5 centimeters residual mass in an NSGCT patient following normalization of tumor markers is surgical resection. He absolutely requires a post-chemotherapy RPLND performed at a high-volume center.
But the CT scan shows the mass is significantly smaller than it was prior to chemotherapy. Why can we not assume the chemotherapy killed the tumor and this mass is simply necrotic fibrous tissue? Furthermore, why not utilize a PET scan to evaluate the metabolic activity of the mass before committing the patient to a highly morbid retroperitoneal surgery?
We cannot rely on assumptions or PET imaging because of the unique pathology of non-seminomatous germ cell tumors. A residual mass in this setting can represent one of 3 things: necrotic scar tissue, viable residual germ cell tumor, or teratoma.
Define the clinical relevance of teratoma in this specific scenario. Why are we so worried about it?
Teratoma is a chemoresistant histologic subtype. The systemic chemotherapy will have eradicated the embryonal or yolk sac elements, but any teratomatous elements will remain completely intact and viable.
And if we just leave it there?
If left in the retroperitoneum, teratoma can undergo unpredictable local growth, which is known as growing teratoma syndrome, or it can actually undergo malignant transformation into highly aggressive somatic malignancies like sarcomas or adenocarcinomas.
And regarding the PET scan, you didn't fully address that.
Right, PET imaging is useless in this clinical scenario because teratoma is notoriously PET cold. A negative PET scan would falsely reassure the clinician, leaving a potentially lethal teratoma inside the patient.
So what is the rule?
The board rule is absolute. Any post-chemotherapy residual mass larger than 1 centimeter in an NSGCT patient must be surgically resected.
I want you to explicitly contrast this with the rule for pure seminoma. If our patient from Block 2 with pure seminoma had undergone chemotherapy and was left with a 2.5 centimeters residual mass, how would your management differ?
The management logic is entirely distinct. In pure seminoma, teratoma is not a concern. Residual masses after chemotherapy are typically composed of benign desmoplastic fibrosis that will slowly regress over time.
So what do you do?
Therefore, for pure seminoma, any residual mass under 3 centimeters is simply observed with serial imaging. We do not resect it.
And if the seminoma residual mass is larger than 3 centimeters?
If a seminoma residual mass is strictly larger than 3 centimeters after chemotherapy, we do utilize a PET scan to guide management. However, we must implement a mandatory delay of at least 6 to 8 weeks, ideally 2 months, after the completion of chemotherapy before obtaining the PET scan.
Why the delay?
This delay is necessary to allow post-treatment inflammation to subside, which minimizes the risk of a false positive reading on the PET.
That is exactly the distinction required for the boards.
Yeah.
NSGCT residual masses over 1 centimeter demand surgery. Seminoma residual masses under 3 centimeters demand observation. And seminoma masses over 3 centimeters demand a PET scan after a 2-month delay.
It's a very clear algorithm if you keep the histology straight.
It is. So to consolidate this knowledge for the listener, I will now recap the 3 most common oral board traps examiners utilize in these scenarios.
Listen up for these.
Trap number 1. anchoring on the original pathology label and ignoring the AFP pivot. If the test prompt says pure seminoma but the AFP is rising, you are treating an NSGCT variant.
Always check the markers.
Trap number 2. Mislabeling a PT2 tumor with LVI and normal markers as stage IA LVI automatically drives the stage to IB.
That's an easy one to miss if you're rushing.
And trap number 3. Stating that primary RPLND is impossible for stage IIA seminoma, or reflexively ordering a PET scan for all post-chemotherapy residual masses regardless of histology.
Right, PET is for seminoma only, and only if it's over 3 centimeters.
Exactly. Okay, doctor, we will conclude your examination with a board blitz.
All right, alrighty.
I will fire 3 rapid-fire multiple-choice scenarios. You will provide the correct answer and a concise justification. Are you ready?
I am ready. Let's do the blitz.
Question 1. A 32-year-old man underwent a right orchiectomy for pure seminoma, PT1. Postoperative markers are normal. His restaging CT now demonstrates a new 1.6 centimeters right para-aortic lymph node.
Okay.
The prompt explicitly states he wants to avoid surgery and strongly wishes to avoid systemic chemotherapy. Which of the following is the most appropriate management? A. 3 cycles of BEPB, modified dog-leg radiation therapy to 20 gray in 10 fractions, with a cone down to 30 gray total. C. Primary RPL-NDD observation with a repeat CT scan in 3 months.
The correct answer is modified dogleg radiation therapy to 20 gray with a cone down to 30 gray total.
Justify.
The new 1.6 centimeters node makes this stage IIA pure seminoma. Active disease precludes observation, ruling out D. The patient explicitly refuses surgery, ruling out C, and refuses systemic chemotherapy, ruling out A. This leaves radiation therapy.
And the dosing.
The stated dosing perfectly matches the standard of care for stage RIA, 20 gray to the prophylactic modified dogleg field with a cone-down boost to the gross disease, bringing the cumulative dose to 30 gray.
Correct. When multiple valid standard options exist, oral board prompts must make patient preference explicit. Question 2. A patient with stage IIB pure seminoma is receiving modified dogleg radiation therapy. Phase 1 delivers 20 gray in 10 fractions to the larger field. What cumulative dose should the gross nodal disease receive after the cone-down boost is completed? A. 30 gray, B. 36 gray, C. 45 gray, D. 50.4 gray.
The correct answer is B. 36 gray. This relies entirely on the standard radiation dosing mnemonic for seminoma, 20-30-36. The prophylactic field receives 20 gray. Stage IIA gross disease is boosted to 30 gray, but stage IIB gross disease requires a slightly higher dose to sterilize the larger tumor volume, culminating at 36 gray.
Flawless. Final question. Question 3. A 28-year-old man undergoes an orchiectomy for an embryonal predominant NSGCT. The local staging is PT2 with documented lymphovascular invasion. Postoperative markers normalize and all imaging is negative. What is his correct clinical stage? A. Stage IA, B. Stage IB, C. Stage ISD, Stage IAA.
The correct answer is B. Stage IB.
Justify.
Negative imaging dictates N0 and N0. Normalized markers dictate S0. However, the presence of lymphovascular invasion in an NSGCT designates the local tumor as PT2.
And the conclusion?
The combination of PT2, N0, N0, S0 is definitively classified as stage IB.
Correct. You have demonstrated a rigorous understanding of the clinical pathways, the anatomical constraints, and the biological nuances separating these disease processes.
Thank you. It's a dense topic, but the rules are very logical once you break them down.
They are. For the listener, the ultimate takeaway is that testicular oral board scenarios reward strict stage and marker discipline. You must tailor your treatment intensity to the exact volume of disease, heavily weighting long-term survivorship and toxicity minimization over reflexive, aggressive interventions.
Definitely. Keep an eye on those late toxicities.
Always. Stage I seminoma dictates surveillance. Stage IIB seminoma over 3 centimeters dictates chemotherapy. And the presence of LVI is the primary stage driver for localized NSGCT. Complete practice oral boards at radonsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.